Thank you for this opportunity to present my research on the impact of neuromuscular reversal agents on postoperative Alias following colorectal surgery, a multivariate analysis. My name is Luke Traeger, and I'm a General Surgical Registrar from South Australia. I would like to thank my co-authors and my supervisors, James Moore and Tarek Samor. We have no disclosures to declare. Postoperative Alias occurs in approximately 1/3 of our patients following colorectal surgery. It increases their morbidity and mortality and doubles the length of stay. The mechanism by which postoperative Alias occurs is mediated in part by the cholinergic anti-inflammatory pathway, which is modulated by acetylcholine. At the end of an operation, neuromuscular reversal agents are given to reverse the paralysis prior to endotracheal extubation. This is done through two agents, either neostigmine, which is co-administered with glycopyrrolate to prevent cholinergic side effects, or Sagamedex. Neostigmine has the potential to decrease the incidence and duration of postoperative Alias. Postoperative Alias occurs as a result of two phases. The first is neurogenic and occurs immediately following surgery. The second phase is inflammatory and occurs from approximately 3 hours postoperatively for a variable duration of time. This is mediated in part by the cholinergic anti-inflammatory pathway. Neostigmine is an acetylcholinesterase inhibitor that increases acetylcholine at the neuromuscular junction. This could influence postoperative Alias through two mechanisms, either by modulating the cholinergic anti-inflammatory pathway or directly stimulating the GI tract as it does in resolving acute colonic pseudoobstruction. Given that Sagamedex does not act on these pathways, this is why we compared the two agents. We performed a retrospective study at the Royal Adelaide Hospital between 2019 and 2021, looking at major elective colorectal surgical cases. We collected data on demographics, operative outcomes, and postoperative outcomes. We did an a priori calculation, calculating that we needed 83 patients per group to reach statistical significance, and we had ethics approval for this project. Our primary outcome measure was GI2, which is a validated composite measure comparing time to tolerance of oral diet and time to first stool. Our secondary outcomes included postoperative Alias defined by not achieving GI2 by day 4, as well as looking at time to first stool, nasogastric insertion rates, length of stay, and complications. We performed analyses comparing neostigmine versus Sagamedex, as well as performing a univariate and multivariate linear regression analyses, looking at which factors independently predicted GI2. Here you can see our patient flow chart of our selection. We had 285 patients after excluding robotic cases, those who were prescribed pyridostigmine, patients who underwent pelvic exenterations, those who received no anesthetic reversal agents, and those who received both agents. We had 2/3 who received neostigmine and 1/3 who received Sagamedex. When comparing patients who received neostigmine and Sagamedex, patients who received Sagamedex were typically older, more overweight, had a higher ASA, and were more comorbid. These patients typically also had a laparoscopic approach to their surgery. This is because Sagamedex gives a more complete reversal in comparison to neostigmine. Hence, patients who are at higher risk of a failed extubation due to incomplete reversal are more often given Sagamedex in comparison to neostigmine. When comparing our outcomes, the Sagamedex group had a statistical but not clinically significant reduction in time to GI2. However, in time to first stool, there was a 1-day reduction in the Sagamedex group. Overall, postoperative Alias rates and nasogastric reinsertion rates were not statistically significant between the two groups. We then performed a univariate and multivariate linear regression analysis looking at factors that influence GI2. On univariate analysis, smoking history, previous abdominal surgery, open approach, colostomy formation total opioid use between days 1 to 4 postoperatively, and Sagamedex was shown to be statistically significant. However, only previous abdominal surgery and colostomy formation were shown to be independently predictive of an increase in GI2 on multivariate analysis. In summary, Sagamedex reduced time to first stool by 1 day. This is likely due to the fact that neostigmine is given with glycopyrrolate. Glycopyrrolate has a 5 times longer duration of action in comparison to neostigmine. Thus, these patients are more likely affected by the anticholinergic side effects of glycopyrrolate, which increases their time to first stool. Overall, neurovascular reversal agent choice did not impact postoperative ileus rates. This is likely due to the fact that the cholinergic anti-inflammatory pathway occurs from approximately 3 hours post-op, and by the time that this occurs, the neuromuscular reversal agents have been eliminated. Overall, colostomy formation and previous abdominal surgery were strongly predictive of an increase in GI2. This is likely due to the fact that patients who receive colostomy formation typically have a more comorbid operation, and patients who have previous abdominal surgery have increased adhesions and increased time taken during these operations. Thank you very much for your time.